Hey everyone, as you know, I have been in school doing evidence-based learning now, and as a whole, our unit has been struggling with the new no urinary catheters after post-surgical, for our post-surgical patients. So I chose to do that as my evidence-based learning, and there's actually a lot of research out there about it. So I gave out all my papers so that you guys could follow along, and that's what I'm following along with on my iPad as my paper. As I talk to you about what is actual best practice that so much research has said, and as I have researched this problem. So, we've discussed in lots of staff meetings about how we are not happy that our patients are no longer having indwelling catheters placed because CAUTIs were never a problem for our unit. And so we've been struggling with that we are actually causing urinary retention for our patients due to the fact that they are coming up with no catheter and then having no urge to urinate because they had a spinal anesthesia done, and so they just don't have that feeling, which then causes bladder retention, which then causes us to have to bladder scan and then out catheterize them multiple times, which causes even more risk for a catheter-associated urinary tract infection. So that was what my research was about. And so the problem is that because of this new initiative this year to try to decrease CAUTIs, it is actually causing urinary stasis and post-operative urinary retention, which is not a problem just for, as I found, not problem just for our orthopedic patients. It's a problem in general that all post-surgical patients are having a problem with. So the Joint Commission wants no CAUTIs. We all know there's this huge fine that's associated with the CAUTI. I think depending on what your hospital is, I think it's either 1 or 2. 1 without a fine, and once you have 2, it's a fine, and then 3, there's a bigger fine. And so on this, because the Joint Commission wants no CAUTIs, our surgeons and our manager have decided that we are wanting to change our entire way we're taking care of patients by reducing the catheters. Not saying that we're eliminating all catheters, but we are reducing a significant amount. So we find that this is a problem for us because we are now promoting urinary stasis. Because of the spinal anesthesia that we are using, our patients are not having their full bladder return, full bladder function return to them, so they can't feel the urge to pee. So then they're getting 900 in their bladder before we know it because of all of the fluid that's intaking. And I think that it's important to know that urinary stasis can also cause a UTI. And because we're having to do so many straight catheters or in and out catheters, that is causing more and more problems for our patients. More patients are having to see a urologist. You have to follow up. So, and then we're also having to keep our patients longer. It used to be that our patients were out the next day. Our patients are having to stay longer because we cannot get their trial to void over with because we're constantly having to catheterize them. And then it also affects their psychological need. We have patients that have never been incontinent before that are having spontaneous voids that we are measuring. We're adding how many spontaneous voids are happening each shift, and they're adding up, and these patients are embarrassed because it's this 50-something-year-old woman that has never had an incontinent episode, and now she's peed down her leg, and that's causing some psychological problems for our patients. Plus, with our knees, we have those Chance dressings, which is this huge dressing, has web roll and an ACE bandage, and it's to compress so that we don't have bleeding issues. Well, when somebody urinates spontaneously, doesn't know that means urine's getting all down in that dressing, and we're either having to change the dressing or we're taking the dressing off, and then if we don't catch it, then it has an increased risk for infection, because we know that urine is sterile while it's inside the body, but as soon as it exits the body, it's not sterile anymore. So this increases the risk because we're having to take that Chance dressing off. It's increasing the risk for bleeding, pain, and bruising. So I know that we've all recognized this. I did a bunch of literature review I'm going to highlight 3 of them. There are 5 total, I believe, that are in my paper that if you guys have any questions, I'll be happy more to answer them for you. The first one I wanted to recognize was the article, The Annals of the Royal College of Surgeons of England. It states that the authors are looking at a study in which the patients have elective total joint replacements. The authors recognize urinary retention causes and the need for catheterization and the increased risk for infection. This increases the risk for joint sepsis. And that's why they believe that a catheter could cause higher risk for infection. So that's just one one journal that said, yes, we are experiencing urinary retention, but we are not having CAUTIs present, so then we will decrease the joint sepsis. So that is where I believe that we're headed, and that's the valid of why we have moved away from urinary catheters. But I just wanted to point out that there's another article that we go over, and it's the study of, excuse me one second, it's the Holloman study, and it talks about it follows men for total hip replacements. And so for men, the study follows 376 men, and following the surgery, 150 of them experienced POR. The study looked at what kind of medicine the patient received, the age of the patient, and some risk factors noted for POR, like body mass, BPH, hypertension, diabetes. The article also addresses whether the patient developed a urinary tract infection after the catheter was inserted to relieve urinary retention. So if we do have to put in a catheter, are we actually causing our patient harm and having increased risk of CAUTI? In the article, it states that because of how quickly we get the catheters out, we are actually not increasing the risk for catheters, that it is best practice to put a catheter in for less than 24 hours, and you do not actually increase the risk for CAUTIs. And then the next article that I wanted to highlight was the article by Niazi. This is a study that when the patient receives spinal anesthesia or oral opioids after surgery, they are more likely to have urinary retention, which makes total sense. After spinal, which is what most of our surgeons use, the legs and the bladder and everything below that spinal go numb. And so because of that, our bladders are having a harder time waking up. And then with the opioid use, because our patients are tired, because they're in pain, they just had this major surgery, we're giving them opioids. Because of the opioid use, we are not having our patients fully awake, so they are not recognizing the urge that they have to avoid. So my participants would be all the patients on our floor. I would have them sign a general release, a consent of information that we can look at their information. I would then, gather all the information, whether they're having urinary retention or not. And then I would also try to use statistics to find trends to see if the patient, if it is a surgeon, if it's a staff, what are the trends, so that we can look at all the patients overall together. And then just because we're not doing just total joint surgeries, I would then use my internet resources to go and gather information that other nurses and doctors have gathered about their POR situations, their post-operative urinary retention statistics and situations, and what has helped them. And then I would send home a mailed survey that would ask the patient, did you have urinary retention issues when you were at the hospital? Did you have to see a urologist after? Or did you not have any problems? Are you continuing to have urinary retentions where you feel like you have a full bladder, but you're not able to empty it all the way? Are you having to start new medicine because of we've noticed this urinary retention. Is this a problem that was before the surgery, or is this a problem now? Then I wanted to look at 3 different things. I wanted to look at the descriptive study, the quantitative study, and the qualitative study. So the descriptive study, it really doesn't follow us, because the descriptive study, as per the definition from my book, which I'll read to you guys, is research designed to describe in detail some process, event, or outcome, such a design is used when very little is known about the research question. This isn't true for us because, in fact, we have a lot of research out about POR, so we just don't fall into that specific category. There's a lot of information about it, and then in general, there's a lot of information that we are gathering. We're gathering the spontaneous voids. We're gathering the straight catheterizations we're having to insert. We're gathering the new indwelling catheters. We're gathering the people that come with indwelling catheters and how their trial of void is going. We have a lot of information. We have a lot of knowledge about this because we're a post-surgical floor. So, but the quantitative study, my study kind of falls into this because we do use a key part of the quantitative research steps, which is assessment, intervention, and evaluation of outcomes. So we assess the patient. Are they having bladder issues? Have they voided? What can we do to help them void? And then we do an intervention if they're not voiding. We do bladder scans. We do intermittent catheterization. We do indwelling catheterization. We then take all those catheters out. We do trial of void. Then we do an evaluation process when they're about to be discharged. Are we able to get them out of a catheter? Do they have to see a urologist? How are they coping? How is their physical and their psychological? Which then brings me down to the qualitative research, which is looking at the holistic approach of the patient. It is not just their physical symptoms, which we care a lot about. It is also their psychological. How is that 50-year-old man that's never had an incontinent episode dealing with psychological? Hey, I just had a spontaneous void in front of all of my family. And, dealing with that, because that can deter the patient from wanting to move. That then says to the patient, I want to use a diaper, which we don't want, because then that will promote skin breakdown. There is so much that leads from that spontaneous void. And then we are also doing analytic interpretation, which is why we have a special staff member that directly follows our new initiative for the catheterization or the non-catheterization of patients. And so, we're doing all of this research of who, what, when, why did it all happen? So when I had to categorize my study, I would say that it is a little bit of the qualitative and quantitative, because it's not just the patient that we're looking at. We're also looking at numbers and how we can fix the problem, but we also care about our patient, and we're trying to figure out how to fix their issue. And then, so when I researched more in the book, it kind of said that my study would fall most into the sorry, my iPad just moved. The integrative review, because it's both the physical response and the psychological response of the patient. I'm sorry, my iPad kind of jumped all around with my talking notes. So I think it's really important that we figure out what is best for our patient. Is it best to go back to the way we did it, where in the first 12 hours we got that catheter out and then they were gone within 36 hours, or are we doing best practice now by doing the no catheterization, and then a few patients do need intermittent catheterization or an indwelling catheter placed? In my paper, I have all of my references listed. If you guys have any questions, I'd be more than happy to answer them. I really appreciate you taking the time to listen to me now. Thank you. Stop it.